So I'd like to first review just what we're going to be talking about today, though I do have to have a financial disclosure because some of what we'll be talking about is vision screening, and I do have a financial interest and want to be sure that that's fully disclosed. I haven't constructed the lecture in a way that should cause any sort of conflict, and the content will be reviewed to make sure that that's the case. So also, I'm going to be talking about the use of Botox and intraocular lenses in children. Neither are officially FDA approved, and so I need to disclose that those uses are off-label for FDA. So let's get on with it. The topics that we will discuss today in order are first cataracts, then strabismus, and finally amblyopia, which really ties in together with vision screening. In fact, all three of these conditions tie in together with vision screening because the key for you in practice is going to be which of these patients need to be referred and how quickly. And that's really going to be the recurrent focus today. Let's start, though, with a case. I had a patient, a 2-month-old boy, and he actually passed his newborn red reflex screening, but then later the parents thought they saw a dark spot in the red eye reflection on a photograph. This is just a family photograph that they saw, and you see they saw this darkness on the right side compared to the left side, the normal red eye reflex. And so in the office, the pediatrician used a direct ophthalmoscope to illuminate both eyes simultaneously and also saw this asymmetry in the red reflexes. Given that the asymmetry was there, the pediatrician referred the patient to ophthalmology for an evaluation. So we'll get back to what happened to this patient, but I first want to give you the knowledge base for what will help in making that referral and understanding what to do next. So a cataract is a clouding of the clear crystalline lens of the eye. And in this image that I've taken here, it's not a normal image of the eye, it's a slit lamp image, so there's a narrow slit of light that's passing through the optical parts of the eye, and it's only reflecting where there is material that can reflect. So there's a little slit through the cornea, then there's blank space between the cornea and the lens, and then here from front to back here, so this is front, this is back of the lens, is the lens, and there's some little spots inside of that lens which are focal opacities that by themselves count as cataract. Cataracts are rare congenitally or to show up in infants, about 1 in 10,000 depending on where you look and how strict you are about the definition. When we try to define them, there are different ways to define them, but probably the simplest is anatomically. There are some that form here in the anterior part of the lens. Then there are zonular cataracts that can form in any of these different zones of the lens as it forms. Then there are posterior cataracts as well. Posterior subcapsular is just under the capsule. Lenticonus was actually what our patient had, which is sort of a bulging out of the lens back here. And then persistent fetal vasculature is when the vessel that connects normally from the optic nerve to the back of the lens doesn't go away and can cause a cataract next to it. So those are the types of the cataract. This is a different view of the lens now to enhance that red reflex, which we can do by moving the slit of the slit lamp straight ahead. And you can see those same little opacities here showing up as relucent areas within the lens. This particular cataract probably isn't visually significant, though if we go back to our patient, that may very well be a visually significant cataract. And it's not really necessarily for you to decide that, because once you see that asymmetry in the red reflex, then that patient needs to be seen, and as you'll see why. So why would a child have a cataract? Well, a congenital cataract, it's about one-third each, as I'll show you in a minute, hereditary, systemic disease, and idiopathic. But then there can also be acquired causes, which tend to be more trauma, systemic disease, and then iatrogenic, generally from treatment of systemic disease. So let's look a little bit more closely at the causes. So hereditary cataracts, which is one-third, are most commonly autosomal dominant. And you can figure that out just by taking a history or even just sometimes examining the parent with a flashlight, though it's easier for us to examine with a slit lamp and see the more subtle cataracts. But still, you can often get that history and see if they're in that first third. Next third is systemic diseases, and we're going to talk about that more. And then the last group is the idiopathic. And about a third of patients, for all the work we do, for all the investigation, we never find out why they had a cataract. So regarding systemic disease, you'll see as you look in books these just huge lists as long as your arm of all the different conditions that can cause cataract. I've tried to narrow it down to the ones that are either more common or more notable or more likely to show up. So they're my favorite causes, if you will, my favorite ones for you to be thinking about. And that includes three types of trisomy plus Turner syndrome can all have cataract associated. And then metabolic disease, galactosemia is notable because of some of the testing that's done, Lowe syndrome because of the family history and because the parents can often have lens opacities, and then the storage diseases. And then intrauterine infection, and I point out rubella cataract because that used to be one of the most common cause of congenital cataracts. So what about acquired cataracts? Often it can be, in some cases it can actually be a congenital cataract that wasn't that noticeable and that progressed. And that, again, our patient had a posterior lenticonus that can often start clear and then turn cloudy over time. Progression of metabolic disease, treatment, as I mentioned, of systemic diseases, steroids, radiation can cause cataract. And then, of course, trauma, that would be kind of obvious most of the time, but not always with kids, you never know. And then intraocular inflammation, such as juvenile rheumatoid arthritis. Trauma, recently there was an article that showed, here's one form of trauma that can cause cataract, these little laundry bags, and this wire came loose from the laundry bag and hit the kid in the eye. And so this is clearly a traumatic cataract because there's also was injury to the cornea that's been sutured up. The iris is all out of place, but then the lens is completely white, so traumatic. An example of a recently published case series of traumatic cataract. The diagnosis of cataract, it may be that, as with our patient, that the parents see an asymmetry in the red reflex on photographs. It's the one place where that red eye reflex is actually helpful. And then on examination at the well child visit, I mentioned the Bruckner Test, which I'll mention several more times today, just taking the direct ophthalmoscope and looking at both red reflexes simultaneously. Or as you try to move in closer and get a look, perhaps a poor view in on one side. It's not that often you're going to see a white dot because often the cataract is a little further back and doesn't just jump out at you. This patient has nystagmus, and this is an older patient, but it was a video of nystagmus that I had available. And if your infant patient has nystagmus like this, then it may already actually be too late to be taking out the cataract to expect to get normal vision back. So nystagmus is one way that patients can present late. Strabismus as well, because if they can't see, then they can't align their eyes. Rarely will an infant be photophobic, but an older child may be if there's cataract. So one more time on the Bruckner test, you take the direct ophthalmoscope, you put the dial on 0, you then illuminate both eyes simultaneously. You put them, so if you're far enough, here you're not quite far enough away, so if you get far enough away, that circle illuminates both eyes, and then you compare the red reflexes for symmetry and look for any little opacities in the middle. So, you know, the first 100 or 200 times you do it, you might not know what you're doing, but by the time you've done 500 or 800 or 1,000, then stuff starts jumping out at you. So what do we do about labs? Because, you know, you'll be working with an ophthalmologist who may or may not want these tests, or if you see it, you may want to go forward. We want to look at urine for reducing substances because of the galactokinase, torch titers because of some of those favorite causes that I mentioned, calcium, phosphate, and glucose, again, for some of the metabolic diseases. Diabetes, that's not going to show up in an infant, but in an acquired patient. And then if, depending on where the patient is, and if they obviously have trisomy 21, maybe you don't need to get a karyotype, but or if they obviously have some genetic syndrome, but if there's somewhere in between, you may need to get genetic testing. Now, I mentioned about the family history and how a third of the cases have a family history. So if you've got a family history positive, then you don't really need to do any of these tests unless you're maybe worried about Lowe syndrome, but then you would know. Unilateral patients, much less likely to need to do the workup unless it's highly asymmetric. If it's a known genetic syndrome associated with cataract, known systemic disease, history of trauma, these are the reasons you can avoid doing a lab evaluation at all. So you often don't have to do one. So what would be the differential diagnosis of a cataract? Probably a false positive on the Bruckner test. So you see an asymmetric reflex, but maybe it's not because of a cataract, it's because of something else. So maybe it's because of nothing. If there's asymmetric ocular pigmentation, or if the pupil size is a little different, then you may get some asymmetry. If the refraction's asymmetric, then there may not be cataract, but you'll see later we want those referred anyway. Corneal opacification, so it's not cataract, but it's still something bad. And then leukochoria, and this is a child who presented to us with leukochoria. You see that that's actually the normal red reflex in this left eye. The right eye is more of a white red reflex, and we looked with our indirect ophthalmoscope, and this patient had a retinoblastoma. So again, there's a long list of leukochoria, but we want retinoblastoma to be on the top because it's relatively common and something that needs to be seen right away. So clearly, once you see the asymmetry, there aren't very many reasons that the patient's going to come back with nothing, with no diagnosis. So when to refer any patient with visible cataract or asymmetric red reflex, patients with strabismus or who've developed nystagmus, you would anyway. Also, if there's a history of congenital cataract, especially if it's in the parents or in siblings, you may want to just go ahead and make that referral to get a dilated examination to look for the earliest changes. History of glucocorticoid use or radiation, you probably already know that anyway, and then systemic or metabolic or genetic disorder that's associated with cataracts. Most of those patients at some point need to get an eye exam anyway. So pretty straightforward, I think, on who needs to be referred in these cases. So why the urgency then? Cataract, the leading cause of blindness worldwide in children and in adults. But when it happens in an adult, they can actually sit for 20 years and not have the cataract out. And then as soon as you take the cataract out, they're fine. But if you have a binocular cataract, there's no input to the brain, and so you get binocular failure of visual development, basically binocular amblyopia. We'll talk about that. And that's the patients with the nystagmus because they have no vision. And binocular, you actually have more time to take care of because then neither eye is getting a head start. Monocular cataract causes a dense amblyopia because now the brain is giving all of its cortical attention to the eye that doesn't have the cataract, and it's not getting anything from this eye, so it's not getting any wiring to the brain. So these are the toughest ones to treat and the ones that we really want to get into treatment and into surgery as soon as we can, for the most part. Because if treatment is delayed, then the vision loss that you're going to get is irreversible. So early detection and referral is essential. That's why you look in the newborn nursery before the patient even leaves the newborn nursery for that asymmetric red reflex. But it's, again, as I mentioned, like in our patient, it's not always going to be asymmetric at birth. Sometimes it'll be symmetric, and even if there's a defect in the lens at that time. So I thought you might like to see a cataract surgery because I think so we're going to go ahead and start it, and we'll also talk about So this is a side view of the eye, and that's a little glitch in the video there that makes it look, I didn't go in that quickly. It was a little more smooth than that. So just showing you how we can get into the eye with these little knives, and then this is infusion on this side, and this is an aspiration port here. You can see there's a little opening there, and that's suctioning the cortex of the lens. And I've edited this just to kind of jump ahead so you can see. So now all of that cloudy lens cortex is gone, and so now we need to enlarge the incision so we can fit an intraocular lens implant in this child's eye. So, so this is the injector, and the lens is kind of folded up inside of that injector, and so just turn a little screw in there until the lens goes in, and then it unfolds itself behind the iris inside of the lens capsule, and that's pretty much it. Edited, it's not that fast in real life, but it doesn't take all that long to get that done. So the treatment, though, we don't do this on all of them. In some cases, you can do observation. It really depends on how big is the opacity, how dark is it, how much is there, does it affect the rest of the lens, and to some extent, where is it located? Not as much side versus center, but that's part of it, but also the further back it is, the more it seems to affect vision. Not that you really need to know that, but so why would we ever treat cataract with glasses? Well, sometimes the opacity itself is kind of small, but there's a big asymmetry in the refractive error, and so we just need to treat the refractive asymmetry that results from the lens focusing power being a bit perturbed, and then surgery for many of these patients. So then what? So now we've taken the cataract. You saw we put in the intraocular lens in that patient, but they don't all get it. And in fact, the infant aphakia treatment study recently completed said, really, for kids under 6 months of age, you're probably better off not putting an intraocular lens in yet. And that means either glasses, but if it's unilateral, then they'd have like Coke bottle lens on one side and no lens on the other side. No self-respecting child is going to wear glasses like that. And so, not even a baby. And so we have to put contact lenses in these babies, and it's pretty scary for the parents. But one of my parents actually put together this YouTube video on how to put a contact lens in a toddler and a baby's eyes, because she had 2 kids affected, and so she got really good at it. And it's kind of an interesting. If you just search contact lens baby on YouTube, you'll add to the 66,000 or so, maybe that's 68,000. Who've already looked at that, watched that video. So contrary to what you might think, one intraocular lens, once it's in there, we try to choose the right power so it can stay there for a lifetime. Now, all of these patients are going to need bifocals because the normal lens, the natural lens, can change shape as you shift focus from distance to near, but the implant or the lack of an implant can't do that focusing, so you need one power for distance and then a second power at near. Amblyopia is really the main cause of vision loss from congenital cataract, so we've got to stay on that with patching. And we also have to watch for glaucoma and see the kids back regularly and try to check their intraocular pressure, which is about as easy as putting in contact lens. Not necessarily fun, but you get good at it. So how do we follow up then? Well, sometimes we need to do more intraocular procedures. I mentioned, you saw how we put the implant in the capsule, so that capsule can become cloudy over time, so we have to open that up sometimes with another procedure. The lens cortex, you saw I aspirated it all, but in babies, in adults it never comes back, but in babies that stuff will reproliferate and sometimes have to be removed. Sometimes the lens just gets moved out of position, often by reproliferating tissue. So strabismus surgery is actually pretty common in these patients as well. They'll need that. And then the big worries are glaucoma and retinal detachment. Not even necessarily the glaucoma as a result of surgery, but just because the eye isn't formed normally. But retinal detachment is a mechanical thing that's because you've been manipulating the eye. So the prognosis then, as you may have figured out by now, is worse if there's unilateral cataract, if there's delayed treatment, if there are associated anomalies in the eye, or if for whatever reason the family is unable to adhere to the treatment recommendations. If they're supposed to be wearing a contact lens and they're not wearing a contact lens, there's no focus, so you might as well have not taken the cataract out. If they're supposed to be patching and there's no patching, then it's not likely that the brain is getting that experience of trying to interpret that not perfect image. But when we can do everything right, when we can get them early, get the lens out, get them in treatment, patching, do all that stuff, we can often have excellent outcomes and even near normal visual acuity and binocular vision and stereopsis in these patients. So back to our case, was referred to ophthalmology, had a prompt cataract extraction, fitted with a contact lens, unilateral, started patching part-time, same week. Then 2 years later, the patient became contact lens intolerant, so we put an intraocular lens in, kept the patching going. Once he was able to sit up and have head position, we gave him bifocals. Then he developed an esotropia, but used Botox actually for that to kind of reboot the eyes, and that had a lasting effect. So now the patient's age 12, he's got 20/20 vision in the right, 20/40 in the, I guess I have that reversed. So he's 20/40 in the eye with cataract, 20/20 in the eye without cataract. He's got some binocular vision, doesn't get all the test, and normal function. So prompt detection, early referral was a lot of work, and actually taking out the cataract, as you can see, is kind of the easy part, but we ended up with a pretty good result. So in summary, cataract early detection is straightforward. Prompt referral is essential for good outcome. You need if you get a good history, you can avoid testing. And then just remember the metabolic causes, the ones that are listed here on the slide. And many patients now have excellent outcomes. So let's move on. We'll touch back on cataract again when we're talking about vision screening, but let's move next to strabismus. So we got cataract, strabismus, amblyopia / vision screening. So for strabismus, I have a case. We'll talk about the types, causes, detection, treatment, and prognosis. So the case, 3-month-old girl, known to have esotropia at a well-child visit. The pediatrician saw the eye turning in, it definitely was, but said, well, just wait for the child to get older. It's hard to say what the eyes are doing at this age. Let's just see. So it didn't get better, though, and the child came in at age 1 for an examination, was confirmed to have this is at about 6 months, was confirmed to have infantile esotropia and scheduled for surgery. So again, we're going to now talk about what does that mean, and then come back to this patient and see, is this the way that I would have ideally liked this case to have been handled? So first of all, what's normal binocular motor and sensory function? Well, we would expect both eyes to fixate in the same place at the same time, and that's no matter where the eyes are looking. They should track together. You should have full eye movements in all directions of gaze, as is shown here. And when those eyes line up and lock in, that you should be able to have binocular vision fusion, if you will, of the two images that the two eyes see into one world view, and that in turn, because each eye has a slightly different perspective, that gives you depth perception. So normal function is good alignment, good movement, fusion, stereopsis. So strabismus is when that doesn't happen and you have misalignment of the two eyes. The visual axes don't converge onto the same point of interest. And it's common. It affects 2 to 4% of the population, and it's definitely more common in siblings who are affected. Family history is definitely strong, and we're actually working now. We're doing an intensive study trying to get to the genetics of common strabismus. Low birth weight also has an effect. Maternal smoking clearly increased the risk for developing strabismus. And any patient, as we saw from cataract, who has poor vision in one or both eyes is going to be more likely to get strabismus too. So let's go through some terminology. The direction of the deviating eye, if it's turning in, a nasal deviation, that's esotropia. If it's going out, that's exotropia, temporal deviation. And then vertical, you can have hypertropia if the eye is higher, or hypotropia if the eye is lower. Then we can also talk about, so that's the directions, and then we can talk about whether it's a manifest strabismus that is spontaneously deviating, or if it's latent that only deviates with one eye covered. So it's atropia if it's spontaneous, or is it aphoria if it only drifts when it's under the cover. So say you cover my right eye, it drifts out. As soon as you take the cover, it snaps back into place. That's aphoria, exophoria. This child had exotropia, but a second later, he's like that. So this patient had an intermittent exotropia. Sometimes you'd see him like this, sometimes like this. It would spontaneously change from one to the other. And that's quite a common condition to see, intermittent exotropia. So many of what causes this to happen, many cases are idiopathic. And there's a lot of debate about what's really going on there. But if there's refractive error, especially hyperopia, farsightedness, if there's vision loss, this child had a cataract and developed an exotropia because the brain didn't know where to put the eye. Genetic syndromes, neurologic disease. We'll get into this in a little bit more detail. So there are four of the four most common strabismus types I just wanted to run through. Infantile esotropia is our patient that we're thinking about right now. Onset is usually not right at birth. They tend not to be turning in, but within 2, certainly by 4 months of age, you're seeing a large angle, constant esotropia. Not intermittent, it's constant, and it's big. And we're going to get back to that because I would have actually liked to have seen my patient earlier. Intermittent exotropia, on the other hand, is comes on later, age 2 to 5 years. That was that last patient I showed you. It can be any size of deviation, but the control can be variable. Sometimes it's just every now and then when they're really tired, will it be spontaneously drift out. Other kids are just like almost always drifting out. They can only pull it together if they're really holding on to it. Accommodative esotropia is related to refraction because when you're farsighted, you have far sight, things are clear at a distance. But then in order to, all of us have to dial in focusing power, positive focusing power, in order to focus on something up close. So as we focus up close, as we generate that, as we dial in the focusing power, our eyes are also wired to converge. But if a child is very farsighted, then he has to, or she has to focus as if something is right here in order to see clearly all the way out across the room. And so that's going to make the eyes cross just through that effort of focusing. So accommodative esotropia sometimes magically just goes away if you put the child in glasses. And then superior oblique palsy, just wanted to get in a little bit of the vertical because this one is common enough that you'll probably see it from time to time. Presents with a head tilt. It might be subtle, it might be severe, and you might not know whether it's because of torticollis, because of the neck, or because of the eyes. And we'll talk a little bit more about that. But eventually you'll be probably sending some of those cases on to us. Some more rare strabismus types that you should know about include incomitant strabismus. Remember I showed the diagram of the eyes all moving perfectly together in all direction. Well, look at this child. The left eye is turning in a little bit here, but the eyes move pretty well to the right. But look what happens when she tries to look to the left. The right eye moves fine, but the left eye doesn't do anything. So this child has Duane Syndrome, which could be a 6-nerve palsy, or it could be Duane Syndrome. The reason I know it's Duane Syndrome is that when she looks to the right, notice how the eye looks smaller, and that's because both the medial and the lateral rectus muscle pull at the same time, so there's disinnervation. So we know it's more than just a nerve palsy, that there's disinnervation. But anyway, that's an incomitant deviation, different in left gaze than it is in right gaze. Brown syndrome is a vertical incomitant deviation that's related to the superior oblique not sliding through the trochlea properly. Mobius syndrome patients have very little abduction because they have bilateral 6 palsies, and they have facial palsy too. And then there are secondary strabismus types. And actually, I guess I shouldn't call those rare necessarily. Vision loss, as we mentioned, trauma, thyroid eye disease, that's actually pretty common in adults, but pretty uncommon for kids. Even kids with like Graves' disease who've got very prominent eyes, they tend not to get strabismus when they're prepubertal. And then intracranial pathology, a cranial nerve palsy. And so that's the thing you have to be worrying about when you have these patients with secondary or acquired strabismus. And then when is strabismus not strabismus? When it's pseudostrabismus. So here's a child, and everybody, family, pediatrician, everybody thought the child had strabismus. But children have flat nasal bridges and prominent epicampal folds. They could be asymmetric, and so it makes the eye appear esotropic. But you really want to look at the corneal light reflex and notice how that dot is really right in the middle of the pupil on both sides. And then if you can, do cover testing. But at this age, cover testing is pretty hard because you've got to be sure that the child is actually looking at the target when you cover from one side to the other. And it makes cover testing, because you never know, unless you do it all the time, whether a child's actually looking at the target, it makes cover testing not a very reliable test for those who don't do it all the time. So what do you do with these patients? Should you refer them anyway? Well, I don't want to get bombarded with kids with pseudoesotropia, but if it's a more severe case or any uncertainty, it's probably better to get them seen, because these patients are slightly more likely to develop true strabismus later. And so, then it's just going to be a question of, you just don't want that question to be left in the air when they're more severe. So, how do you evaluate a child who has strabismus? Well, we certainly want the family history, as we've discussed. Developmental delays often associated with strabismus, so good to know about. The onset and duration, the sudden onset strabismus, that's a bigger deal. That's a big deal compared to the gradual onset. And the duration is also important when it comes to treatment. Constant versus intermittent, good to know. And then we've talked about some of these other things. The tendency to turn or tilt the head, I didn't go into a lot, but the superior oblique palsy patients, they're going to be tipping their head over. Some of these other patients with concomitant strabismus, that's why they're doing it, is they're trying to find the place where their eyes line up, because people really want to have binocular vision. Frequent squinting in the UK, they call strabismus squint, because especially exotropia, kids tend to squeeze one eye closed. So this would be unusual: stumbling, double vision, difficulty judging distance, except in those acute, sudden onset strabismus that can happen in an older child who's had something go haywire, and those are the ones you worry about. Other systemic disease or symptoms, and obviously trauma. So, child comes to your office and you're doing your strabismus evaluation. How do you decide whether they have strabismus or not? Well, the corneal light reflex that we saw is useful at all ages. Remember that last patient I showed with that pseudostrabismus? The light reflex were perfectly centered. Here, this one's perfectly centered. It's looking at us with the left eye, but oops, look at that one. The dot's up here, the pupil's down here. So that's a big right hypotropia. The Bruckner test would actually, even though there's no cataract, the Bruckner test will show up asymmetric in this patient. And it's actually this eye, the deviating eye, that's going to have the brighter light than the fixating eye for various obscure reasons, not worth going into. And then you can always try cover testing. You can tell them. And then there's photographic and automated methods that we won't be talking about very much. But here, the photographic method is quite helpful because we can scrutinize the picture in a still child instead of a moving child. So, yeah, so when we're looking at the corneal light reflex, you hold the small bright light source near your eye. So you want to kind of be you don't have to be perfectly coaxial, but you kind of want to be on line with it. And then you aim the light at the child's eye and attract their attention, and then look at the reflection. Compare it with the center of the pupil. Normal. There's an esotropia. Here's an exotropia. You have to ignore. You have to just ignore the sclera, ignore the eyelids, so that you're not fooled by the pseudostrabismus patients. Then the cover-uncover test. I sort of already talked about that, but just to be a little bit more specific, Again, patient needs to be fixating on a target, and they need to be interested enough in it that when you switch and cover the other eye, they're going to keep looking at it so that you can be confident the eyes move. So cover the right eye, and now we're going to watch what happens. So target's out there, cover the right eye, and then watch what happens to the left eye when you cover. If you see it shift to pick up fixation, then you've got atropia. And then uncover it and pause for a second, and now cover the left eye. And if you now see the right eye shift to pick up fixation, then again you've got atropia. You're less excited about what happens to the eye under the cover because that's aphoria, which usually isn't clinically that important. It's the manifest, the tropia that's associated with reduced binocular vision and what you want to pick up. Head tilt or turn, I mentioned. This is a boy I saw who was always like this. And he was always like this because, look, when I finally got him to look to the left, the right eye up and left, the right eye went up, but the left eye wouldn't move up. So he's seeing double over there. So he's not going to accept that. He wants binocular vision. So he's turning his head to keep it right. Some of those patients will have facial asymmetry. They'll be squinting one eye closed sometimes. So any other testing you're going to do? Neuroimaging, not for your congenital esotropia patient, not for your accommodative esotropia, not for your intermittent exotropia patient, but it's those sudden onset strabismus. He was fine until Tuesday morning. He woke up, I saw the eye was crossing, he was stumbling, he didn't want to play on the swing set that he usually plays on. Those patients have got something going on. Maybe, although actually sometimes they don't have anything going on, but it's only one, you do need to find out. So severe headache, other neurological findings, the usual things that you would expect might make you want to work it up over and above just the fact that they have strabismus. If there's, in the books they talk about getting some blood work if you think it's associated with some inflammatory disease. It's just clinical judgment there, though. So when do you refer? In infancy, so this is a distinction that, at least in Boston, I don't see happening that often, because I rarely get to see patients like our patient that we're following when they're 2 months old. Now, exotropia is common in newborns. In fact, probably most newborns are somewhat exotropic, and they're kind of in sometimes, they're out sometimes. You don't really worry about, in meaning straight, drifting outward, kind of floating around. They're not really there. So I don't worry about exotropia in the first 6 months or so. And even if there's maybe intermittent esotropia, that's probably okay too. But if you have a constant esotropia even in a child who's just a month old or 6 weeks old, we want to see those patients because sometimes because the earlier you get them into care and intervention, the more likely you're going to get a binocular outcome. So I'm not sure if that's in the books, but this is what it's in this book. If you're confident that there's a constant large angle esotropia, there's absolutely no reason to sit on that. And besides, if it's constant large angle esotropia, how do you know it's not a constant strabismus because the child can't see out of one eye and doesn't know where to put it? After infancy, if there's strabismus visible in the office, if the parents are concerned that they might have seen it, and even if you don't see it, because the screening tools that we have aren't all that great, it's something that you may want to make the referral. And torticollis not explained by the musculoskeletal exam. So big head tilt, and it kind of feels tight, but it doesn't really seem that tight. Or if there's torticollis and you put a patch over the eye, and if their head straightens out, then that would tell you that they're doing it to try to use the eyes together. So treatment of strabismus, glasses alone for accommodative esotropia, as I mentioned. It relaxes that focusing effort and allows the eyes to straighten. And sometimes even kids who have big angle, we'll still put them in glasses if they're hyperopic, because it'll reduce the angle of strabismus some by relaxing. But those who have the larger angles, when we're trying to promote binocular vision, we will do some kind of intervention. So incisional surgery is still the standard. This is an example of a muscle recession, So this is the left eye, and say this patient probably had exotropia, which means the eye was going too far off to the left. And so by taking the muscle off and then sort of hanging it back by a certain number of millimeters, it'll heal back down. The cut edge will heal down back there, so now it's not as taut on the eye, and so that's going to allow the eye, the resting position of the eye, to move inward. You can also do a resection by, instead of putting the suture at the muscle, you put the suture back somewhere and cut out a little piece of muscle, and then you close that gap, and when you close that gap, then you've strengthened the muscle. So that's still the standard same-day procedure. Kids are usually back to normal within a couple of days of having the operation. Botox injections are even less invasive. It just takes a few seconds. It temporarily paralyzes the muscle, but unlike with wrinkles, with strabismus, Botox can have a permanent benefit. And the reason is that, say a child has esotropia, and you inject the medial rectus muscle, so you're going to paralyze that muscle for about 3 months. During that time that the muscle is paralyzed, the lateral rectus muscle is gaining strength, the medial rectus muscle is on stretch, and so it's going to change. You can get muscle length adaptation, just as you would if you put an arm in a brace and held it there for 3 months and didn't let the patient move it. So you can get, but that sounds bad. But it's actually kind of neat, because sometimes we'll go in 30 seconds in the OR, 10 minutes in recovery room, and they come back and you avoided surgery. So I've just talked about recession, resection. Post-op pain is mild. Usually we just give kids ibuprofen. Some people talk about nausea with strabismus surgery, but I think that was back when they gave them too many narcotics on the day of surgery. We've kind of backed off on that, and we don't see nearly as much post-op nausea and vomiting anymore. So some kids, especially the older kids, may see double, especially the kids who are exotropic, who are intermittent exotropes, because they're used to fusing, and they're used to sort of shutting it off when the eye goes out, but we have to overcorrect them and send them home with their eyes turning in, and so that's going to give them double vision for a while until things kind of settle and the eyes go back to where they were supposed to be. It's going to be red. It's just eye surgery. So the things we worry about as surgeons would be post-op cellulitis, preseptal, orbital, any sort of we don't like that. It's pretty uncommon though, and nowadays most of us stay in touch with our patients. It's easier for patients to get in touch with us when these things are brewing, but still you may find yourself in the middle of a post-op cellulitis. Scleral perforation we worry about during the surgery, because once you've gone all the way into the eye with a needle, then you have all the risks of retinal detachment and endophthalmitis, and you can have, there are cases where patients, the needle goes in, they get an infection, and the infection goes out of control and they lose the eye. So all parents have to be warned about that. Exceedingly rare, but the risk that we undertake when we do strabismus surgery. The more common, what are the complications of strabismus itself? Reduced binocular vision that we talked about, because there's a critical period for developing your binocular vision as well, and that closes in the first 12 to 24 months of life, but really it's closing every day in terms of the level of binocularity that you're going to get. So that's why with those infantile esotropia patients, I like to see them early, because I want to try to give them the best chance to have the least amount of time where the eyes are misaligned to get them straight. And if I could get them early enough, then it's within reach of Botox instead of having to do incisional surgery. Maybe not all practitioners are this way, and maybe in your community you'll start sending them early and you'll get them back. I don't know, but I doubt it. Amblyopia is the other complication, which we'll talk about more. Why would you get amblyopia when you have strabismus? Well, a younger child, the eyes are misaligned. So, here's one TV set here, but then the other side is looking over there, so there's going to be a second TV set, and that's too confusing. And kids' visual systems and brains are plastic enough that they reconcile that by just shutting off one image and just choosing one favorite eye. And that's how you get amblyopia, is because of this suppression. You might as well have a cataract in there, or you might as well have a patch over the eye. they've suppressed, and so they get amblyopia if it's untreated. So you don't actually have to treat the strabismus to make the amblyopia go away, as long as you just do patching, and we'll talk about amblyopia more in a minute. Double vision, if you get acquired strabismus. Head and neck problems from years of torticollis that kids can develop from having strabismus. And then let's not forget about the psychosocial complications of strabismus. Now, in young children, it's less of a there's less fuss about it because we all know we're trying to also preserve their binocular vision. But in older kids, teenagers, young adults, older adults, there are hundreds of studies that document social function is impaired when people have strabismus. The job opportunities, you ask people about promotion, who would you promote, and the ones with strabismus get lower scores. Dating studies, who would you pick as your partner, the one with manifest strabismus get lower scores. There's difficulty communicating. I have teachers that their students don't know who they're calling on, and so it's a real problem. It's not there's only one normal position of the eyes, and that's straight ahead. And if it's not straight ahead, that's not a cosmetic or an aesthetic issue. That's a disease, and it needs to be treated. And so insurance companies, almost all now consider strabismus surgery medically necessary in children and in adults. How do patients do? Well, the outcomes vary with the type of strabismus. Unfortunately, even with those infantile ET patients, even if we get them early, they develop other things, vertical misalignments and other such things. So the lifetime reoperation rate of many of these strabismus forms is as much as 50 to 75%. That doesn't mean you shouldn't do the first operation, but just everybody has to be prepared that whatever went wrong that let the eyes go out of alignment, you're not taking that away. You're trying to get them back straight and hoping if you reset that it'll lock in, but it doesn't always. The short-term reoperation rate, I usually cite about a 20% reop rate when I talk to parents. But it is clear that the shorter the duration of the strabismus, the better your binocular outcome is going to be. So we like to get them in treatment. The Botox re-injection rates are higher, but again, it's minimally invasive, so it's, for many people, more acceptable. And as I just mentioned, the vertical deviations. So back to our patient. For me, it was a delayed referral. The onset was 3 months. Everybody knew it was there. Didn't get to see the child until 1 year of age. Fortunately, didn't develop amblyopia, had equal vision, but or at least I'm sorry, this patient did develop amblyopia. I was thinking of another one. So the surgery improved the alignment, but the patient never developed binocular vision, wasn't able to see 3D on the 3D test, and maybe wouldn't have even if I'd gotten the patient at 3 months, but we won't know. Did develop amblyopia in one eye. Vision is better with patching, but not back to normal. And now, at age 6, is developing exotropia with discussion for additional surgery. And like I said, it's just part of this condition is that, it's not locking in. So you're going to have to expect that. Again, that doesn't mean you don't treat. You still want to treat because you don't want to just let them sit there and have to have this big strabismus. But you just have to be ready that you may be back for more. So in summary, strabismus may be difficult to detect reliably, especially the small angle, the intermittent, when it's overlaid on, so you have pseudostrabismus and true strabismus. But early referral of constant strabismus helps us initiate treatment and have better outcomes. The red flags are double vision, sudden onset, incomitance of the deviation, different in different gazes. And the treatment can be as simple as glasses to Botox to surgery. So that's strabismus, and so I want to finish with amblyopia, but then amblyopia leading into vision screening. So we have one more patient for the hour. A 4-year-old boy fails a vision screening at the pediatric office, and this is not just a true story. This happens a lot. The parents were advised, well, kids fail this test all the time. We'll just check them again next year. So he comes back And they're fine with that because they're like, yeah, he sees fine. You can see a tiny little bird in this tree. You'll see a little airplane in the sky. He's got good vision. I don't know why he would have failed that test. So then takes again the next year, and it's like, oh, yeah, he was having a bad day. I think it's just, and so no referral. But then fails again at age 6, and now people are worried. Patient gets referred for possible for vision loss, question amblyopia. So let's talk about then what we need to think about as we approach this patient. Amblyopia, as you may have sensed by now, is vision loss in a structurally normal eye, resulting from a lack of visual input. That is to say, if we take a brand normal baby, newborn baby, structurally normal eyes, and if I put an eye patch over one eye and leave it there for 4 months, when I take that patch off, that eye is going to be blind. And it was a normal eye. Even in a few weeks, you're going to lose vision, really. Now, we don't go putting patches on babies' eyes, but you've already seen cataract, you've seen strabismus with suppression, and you haven't really seen much of anisometropia, which is asymmetric refraction, which we'll get to. But these things do happen where you get deprivation and you lose vision as a result in 1 to 4% of patients. So I already said it was like 1 to 4% strabismus, or 4% amblyopia, but some people with strabismus have no amblyopia, and some people with amblyopia have no strabismus. So put them all together, I think they add up to about 5%. And if we can get them early and treat them, that's going to be the message, then we can restore vision to normal in many cases. So I've just talked about the different types, but let me be a little bit more exact. So deprivation is the worst form, the hardest to treat. That's those unilateral cataract patients, or like complete ptosis or other things around the eye that just completely blacks out the eye. That is profound and really hard to get back from. Strabismic amblyopia is the next most difficult to get back to normal. That's where the brain's just shutting off one eye to inhibit double vision. And then anisometropic amblyopia is where one eye, so imagine one eye is best focus here without having to work this far away, and the other eye is in best focus out here. Well, it turns out that or say it's, I want to try to get this right. Say this eye, you have to hold something like all the way up here to see anything clearly, whereas this eye, you can hold it out here. Well, if a child's just holding with both eyes open, this eye's already in focus. This one's going to be out of focus. They don't know that, so this eye's not getting a clear image. Oh, I don't know if or let's say, and so that's anisometropic amblyopia from asymmetric refractive error. One eye is chronically defocused, so it never gets the proper input, so the brain doesn't learn to see. That turns out to be relatively easier to treat than the others, but because it's so hard to diagnose, because there's no symptoms, the eyes don't look misaligned, there's nothing there. And so these are the ones that get missed too. And so they get missed so long that we can't treat them after all. So amblyopia, as a result, even though it's almost completely treatable if detected early in life, is the leading cause of monocular vision loss in children and adults under age 45. It's almost all because of the difficulty in detecting the disorder. It turns out half of all cases in the U.S. are missed until school age. Patients with amblyopia have double the lifetime risk of total blindness because they don't have a spare eye that they can rely on. They have reduced depth perception. It's not just from strabismus, but if the vision is poor enough in one eye, the depth perception is going to be off, and that's going to limit career opportunities. And I found one study that showed that children with amblyopia are more likely to be anxious and depressed, for what that's worth. So what are the principles of treatment? The classic number one is you correct the underlying refractive error. So you want both eyes in focus the same place at the same time all the time, and then you're not going to have one eye. They don't have to choose between one eye or the other. And then the other underlying principle is to encourage use, if you will, of the amblyopic eye. So if the left eye has the amblyopia, then you need to do something to get the brain to pay attention to the left eye. That can either be occlusion with a patch, or some people will even put a filter over the lens. Blur pharmacologically by putting in an eye drop. If you've ever had your eyes dilated at the ophthalmologist's office, and it's really hard to see up close because you lose that accommodation. You can't focus and shift your focus from distance to near anymore. So blur. And then optical in some cases where you give glasses that are, say, too strong over one eye to force the other eye to focus, used less commonly. So the patch and the atropine are, there have been a number of randomized clinical trials saying they're probably about equally effective. But many families just can't keep the patch on the child. But with the atropine, you just like hold them down, get it, just get the drop in, and then you're all set for the day. So a lot of families do prefer the atropine penalization, but some don't like the idea of putting in the drops. Now there are newer treatments that are on the horizon, just coming into use through some clinical trials that are ongoing now. I'm not sure where they're going exactly, but they involve binocular therapy, avoiding patching or penalization, and encouraging binocular vision. So you may have read about iPad treatment for amblyopia. So kids are wearing 3D glasses, and there's differential contrast to sort of force them to try to be binocular in order to get through the tetrascan. So that's showing some promising results. It's still early. Whereas you may have also heard about taking L-DOPA and other medical therapy to try to change the plasticity of the brain, and so far there's not any evidence that those are effective approaches. We've really been fortunate in pediatric ophthalmology to have this Pediatric Eye Disease Investigator Group, which is funded by the National Eye Institute, and it's a group of investigators that are clinicians out in the world who are part of this group with a oversight committee that comes up with the studies, and then you don't have to go through the whole grant process every time. You just say, let's do this clinical trial next, and then you call up the investigator and say, we want to do that. So there have been 21 studies, randomized controlled trials, related to amblyopia to refine and enhance the way that we treat this condition. So how do patients do? With early detection and treatment, most patients will recover good vision, and the better they adhere to treatment in general, the better the outcomes. Of course, you're going to have some who are more severe, and maybe that's why they won't wear the patch, because they're so profoundly, because maybe they had never had a chance to get better. But for the most part, the hours of patching worn up to maybe about 4, maybe 6 per day seems to correlate with the recovery of vision. It's not easy to keep an eye patch on a kid who can't see out of the eye that you're forcing him to use. But delayed detection and treatment results in early irreversible vision loss. Partial improvement can be achieved up to the teenage years, but in those studies, yeah, they got better, but they read maybe just a couple of lines, letters more on the eye chart. So back to our patient then, was referred to an ophthalmologist, and sure enough, 20/20 in the right eye, 2200 in the left eye. There's 3 diopter asymmetry in the refraction, with the left eye +5 and the right eye more like +2, which is kind of typical for age. And so this patient had anisometropic amblyopia, no measurable strabismus. After 2 years of glasses, patching, atropine, doing all of the things that are done for amblyopia, the vision remains today about 20/60 in that left eye. Sometimes we'll get a save at that age and get it all the way back, but in this case, no. So to summarize amblyopia, it develops when the brain does not receive an image from a structurally normal eye. So amblyopia happens in structurally normal eyes. We've talked about the treatment, correct the refractive error for sure, and then occlusion or blur, something to hinder the fellow eye to give the other eye a chance, though maybe binocular therapy is coming along. Early detection, you get good results, but because of limitations in how screening is performed today, half of all cases go undetected until kindergarten. And so that's why I wanted to spend just a few more minutes talking about the vision screening imperative. Cataracts, strabismus, and amblyopia outcomes are all improved with early referral, but the pediatrician during a well child visit has a lot to do. other than try to be a pediatric ophthalmologist. We get to spend our whole time with the patient just checking their eyes. So more subtle forms of these conditions are difficult to detect, especially in the youngest children when you want to detect it most. So what happens? Right now, a lot of practices just don't even do vision screening. Either they'll refer all the kids to an ophthalmologist or an optometrist, which is kind of a waste of resources, really, or just don't screen, period. Manual visual, what I call manual, just trying to have kids read an eye chart, a wall chart, or the vision screening machine. About half of practices do that. And that's okay for verbal kids, but that, yeah, age 6, age 7, they're going to do it, but you're not going to get a 2 or 3-year-old to do very well on an eye chart, and that's when we really want them. So instrument-based vision screening has been coming along. That's only at about 10% adoption at this point. So, as I say, manual screening is difficult. Instrument-based screening seems to be a step up, but the problem is it's detecting risk factors for disease, but not necessarily detecting the kids who have strabismus. They can't detect strabismus, the current instruments, and they can detect refractive error, but not every child with some refractive error has amblyopia. So they end up having a high referral rate, and so some offices that use them like them, but others find that they're referring too many kids. So there's still a challenge. There's still no really good way. But the instrument base is good enough that the AAP now has an official endorsement of instrument-based vision screening, and furthermore, many payers are now paying for instrument-based vision screening with the 99174 code, and so it's now feasible to be doing this testing and getting paid to spend the extra time to have the resources to get the testing done. There are future technologies in development that may allow for direct detection of amblyopia, strabismus, and cataract. For now, though, it's either manual exam, instrument-based autorefractors for risk factors, or send every child to an ophthalmologist or optometrist. So, to summarize, cataract, strabismus, and amblyopia all can cause profound and lifelong visual impairment. The cataract, over and above that, may herald a metabolic or systemic disease. Strabismus may be the first sign of neurologic disease or vision loss, but all three conditions respond well to timely treatment from glasses, whether it's glasses or surgery. And so, so those are really my main take-home points for you. Is as I've said enough, and depending on where you're watching this, perhaps it's helping you to fall asleep by hearing me repeat it over and over enough times. Early detection, early referral makes for the best